Hi everyone, our subject today is speech delay. Basics. Speech delay is a delay in acquisition of spoken language. Language is a system of symbols through which humans communicate thought, feelings, and ideas. It has three components: receptive, expressive, and visual language. Receptive language is the ability to process and understand language. Expressive language is the ability to communicate through speech, written or formal sign language. Visual elements include eye contact, pointing, and gesture. Speech delay can be primarily as a specific language impairment or developmental language disorder, or secondary to another condition such as syndrome or neurological disorder. Specific language impairment is impaired speech or language in otherwise normally developing child who lack sign or stigmata of other condition. Constitutional language delay, a retrospective diagnosis, is language delay associated with eventual achievement of normal speech and language milestone by school age. There are no subsequent difficulty with the learning or reading or write. Expressive language disorder include the following: verbal dyspraxia, little speech produced with a great effort, very disfluent, single word most commonly. Speech programming deficit disorder, poorly organized, difficult to understand speech. Mixed receptive and expressive disorder, verbal auditory agnosia, impaired ability to decode speech, resulting in a severe expressive impairment, can often learn language visually. Phonological syntactic deficit disorder, most common type of developmental language disorder. Comprehension exceeds spoken ability. Speech is disfluent, grammatically incorrect, with short utterance. Most frequent cause of speech delay: hearing loss, specific language impairment, autism spectrum disorder, and intellectual disability. Risk factor for delayed language: family history of speech delay or disorder, male gender, low maternal education, maternal depression, prematurity, birth weight less than 1 kg. History: does the family note a concern about speech delay or hearing impairment? Question: perinatal history, significant prenatal care, maternal illness, neonatal care admission, hyperbilirubinemia, requiring exchange transfusion, treatment with ototoxic drugs such as gentamicin, newborn hearing screen result. Question: full developmental history, significant to determine if global delay or isolated speech and language delay. Question: parental concern about delayed expressive language, significant often presentation of autism. Question: history of feeding, swallowing difficulty, or poor acceptance of textured food, significant sign of oral motor dysfunction which may indicate neurological problems. Question: family history of speech delay, hearing loss, neurological disorder, or syndrome, significant, may direct further evaluation. Question: any regression or loss of language milestone, significant, should prompt a neurological and metabolic workup. Question: what is the social interaction of the child? Significant, lack of interest in playing is a red flag for autism. Question: any concern regarding child abuse or neglect or psychosocial deprivation, significant, may have occurred as a result of a parental, genetic, or developmental disorder, drug or alcohol abuse, poverty, child malnutrition, or environmental toxins such as lead. Question: history of frequent acute otitis media or otitis media with effusion and conductive hearing loss, significant, may precede speech delay. Question: visual impairment, significant, may impact speech development because interpretation of facial expression and gesture is a component of infant receptive language development. Question: history of traumatic brain injury. Significant speech delay may occur with seizure disorder. Physical examination. Complete examination looking for signs that may be associated with the speech delay. Finding microcephaly, significant, associated with intellectual disability, in utero cytomegalovirus infection or dysmorphic feature. Finding macrocephaly, significant, associated with hydrocephalus and various syndromes. Finding dysmorphic feature, suggestive of syndrome. Finding excess drooling and open mouth posture, significant sign of poor oral motor control of muscles used for speech production. Finding craniofacial abnormalities, significant articulation difficulty may be due to velopalatal insufficiency seen with the unrepaired cleft lip or palate. Finding scared tympanic membrane or middle ear fluid, significant, may be clue to acquired intermittent or chronic conductive hearing loss. Finding macroorchidism, significant, fragile X syndrome. Finding neurological exam, hypertonia or hypotonia, abnormal reflexes, other focal finding, significant, suggestive of neurological impairment. Finding cafe-au-lait spot, hypopigmented macules, chagrin patch, axillary or inguinal frecklings, significant, skin finding suggestive of neurocutaneous syndrome. Selected speech language milestone: 2-month cooing response to voice, 6-month babbling, 9-month turn to sound response to name, more than 9 months dada, mama, non-specific, begin to understand, no, below 1 year jargon speech, more than 1 year dada, mama, specific, 1 additional word, jargon incomplex, point to gesture, follow 1-step command, 18 months, 10 words, known body part. 2 years, 50 word, 2-word phrases, 50% intelligible by stranger, pronouns, can point to specific object in a picture, may know 1 color, follow 2-step command. 3 year, 300 to 500 word, tell stories, 75% intelligible by stranger. 4 year, grammatically correct tenses, 100% intelligible by stranger. Red flag, which indicate immediate referral. Below 1 year, difficulty sucking and feeding, avert gaze, fail to make a variety of sound, fail to respond to name, undifferentiated crying. Below 2 year, no specific mama or dada, does not point, cannot follow simple direction without gesture, reduced vocabulary, no word combination. Red flag below 3 year, avoid eye contact, reduced communicative intent, difficulty following direction, lack of verbal expression, reduced reciprocity and turn taking, talking better than listening, poor conversation skills. Below 4 years, does not engage in back and forth communication for purely social reasons, does not talk about what communicative partners are talking about, use language that is repetitive or recycled from other contexts. Below 5 years, weak ability to hold a conversation, cannot tell a personal narrative, difficult with the sequencing information. Alert: avoid late referral of congenital hearing loss. Amplification and therapy by 6 months of age can result in near normal rate of speech language acquisition. Constitutional language delay is a retrospective diagnosis. Do not miss language disorder if assuming a delayed toddler is a late bloomer. Avoid overlooking fine or gross motor delay. Avoid missing a genetic or neurological disorder. Recommended investigation. The American Academy of Pediatrics recommend a specific developmental screening tool to be administered at 9, 18, and 24 or 30-month well-child visit, and an autism-specific tool be administered at 18 and 24-month visit. Office Development Screening Tool, Denver Development Assessment Tool, Early Language Milestone Scale, Clinical, Linguistic, and Auditory Milestone Scale, Routine cranial imaging or screening test for metabolic disorder are not recommended. Hearing evaluation, Universal Newborn Hearing Screening Program, screening test, automated auditory brainstem response, and transient evoked autoacoustic imaging. Hearing should be tested in all speech delay children, even if the newborn hearing screen was normal. Below 6 months of age, the definitive test is brainstem auditory evoked response. More than 6 months of age, in a neurologically normal child, the definitive test is behavioral audiometry, such as visual reinforcement audiometry, performed by a trained audiologist. Full speech and language evaluation, significant to delineate the disorder and determine therapy. Individual with the Disability Education Act mandate early intervention service from birth to 3 years. Significant children can get a full developmental evaluation and appropriate therapy if sufficient delay are demonstrated. EEG significant indicate if there is concern for seizure. Genetic evaluation should be obtained for congenital hearing loss or if there is concern for syndrome or genetic diagnosis. Prolonged sleep EEG indicated with loss of language milestone, consider the diagnosis of Landau-Kleffner syndrome. Frequently asked question, do second and third born children speak later than the first born children? Answer, no. The norm for expected speech language development are the same regardless of the birth order. Second and third born children should have the same degree of motivation to speak as their firstborn sibling. Question, do children raised in bilingual household have expressive language delay? Answer, no. Living in a bilingual household is not a cause for expressive language delay. However, toddlers who are learning two languages may interchange words in both languages. Total vocabulary and phrases length and are typical normal in these children by 2 to 3 years of age. Question, when should I refer a child for speech language evaluation? Answer, if the parent or physician have any concern for speech delay, the referral for evaluation is wise. Some speech delay children will eventually normalize and meet all milestones. It is difficult to distinguish who is constitutional delay from those who have another disorder. There are several indications for prompt referral. No pointing or babbling by 1 year. No single word by 16 months. No two-word spontaneous phrases by 2 years. No stances by 3 years. Poor intelligibility for age. Child has behavioral meltdown or tantrums with the effort to communicate, or any regression in language skill. Differential diagnosis, hearing loss, isolated hearing loss, hearing loss secondary to in utero cytomegalovirus infection, full syndromic at birth, or asymptomatic infection with delayed onset of progressive hearing loss, acquired hearing loss following head trauma, tumor-associated complication of bacterial meningitis, and result of frequent acute otitis media or chronic otitis media with effusion. Other causes, intellectual disability, autism spectrum disorder, specific language impairment, constitutional language delay, selective mutism, environmental, lack of stimulation and poor linguistic environment, child abuse or neglect, lead poisoning. Congenital causes like cerebral palsy, hydrocephalus, Down syndrome, Fragile X, DiGeorge, fetal alcohol, Turner, Klinefelter, Prader-Willi, Angelman, muscular dystrophy, tuberous sclerosis, neurofibromatosis, Williams syndrome, brachioautorenal syndrome, craniofacial anomaly such as Treacher-Collins and Goldenhar syndrome. Nutritional, malnutrition, and iron deficiency anemia. Infection, HIV, encephalopathy, other in utero viral infection, congenital toxoplasmosis, and congenital syphilis. Thank you for your